this respiratory therapy program. I'm going to do an overview of 4 different types of shock. We will be discussing cardiogenic and obstructive shock in this video. The word shock is used differently by the medical community and the general public. The connotation by the public is an intense emotional reaction to a stressful situation or bad news. The medical definition of shock is much different. Medically, shock is defined as a condition where the tissues in the body don't receive enough oxygen and nutrients to allow the cells to function. This ultimately leads to cellular death, progressing to organ failure, and finally, if untreated, whole body failure and death. Today, I will cover cardiogenic and obstructive shock and how they affect the body. Cardiogenic shock is a physiological state in which inadequate tissue perfusion results from cardiac dysfunction, most often systolic. Cardiogenic shock is a major and frequently fatal complication of a variety of acute and chronic disorders. Cardiogenic shock often occurs after an acute myocardial infarction. Cardiogenic shock is the leading cause of death in acute myocardial infarction, with mortality rates up to 70 to 90% in the absence of aggressive, highly experienced technical care. All patients with cardiogenic shock require close hemodynamic monitoring, volume support to ensure adequate and significant preload, and ventilatory support. Assessment findings. The diagnosis of cardiogenic shock can sometimes be made at bedside by observing the following: hypotension in the absence of hypovolemia and by signs of inadequate tissue perfusion. Findings on the physical exam would include the following: skin is usually ashen or cyanotic, peripheral pulses are rapid and faint, jugular venous distension and crackles in the lungs are usually present, peripheral edema may also be present, heart sounds are usually distant, the pulse pressure may be low, and patients are usually tachycardic. Patients show signs of hypoperfusion, such as altered mental status and decreased urine output. Ultimately, patients develop systemic hypotension, which is systolic blood pressure below 90 torr, or a decrease in mean blood pressure by 30 torr. Diagnosis. EKG should be performed immediately to help determine if cardiogenic shock has in fact been caused by acute myocardial infarction. An echocardiograph should be performed as soon as possible to help determine the cause of the cardiogenic shock. Swan scans catheterization is useful in helping to exclude other causes of shock, for example, hypovolemia. The hemodynamic measurements of cardiogenic shock are a pulmonary capillary wedge pressure of greater than 15 torr and a cardiac index of less than 15 torr. You would find a pulmonary capillary wedge pressure by inflating the balloon, and then it would reflect the pulmonary capillary wedge pressure. Cardiogenic shock is an emergency requiring the following: fluid resuscitation to correct hypotension unless pulmonary edema is present, prompt initiation of pharmacologic therapy to maintain blood pressures and cardiac output, which I will discuss further later, admission to an intensive care unit, early and definitive restoration of coronary blood flow, corrective action of electrolyte and acid-base abnormalities, placement of a central line, placement of an arterial line, placement of an intra-aortic balloon pump. Pharmacologic therapy. Patients with myocardial infarction or acute coronary syndrome are given aspirin and heparin. Inotropic and/or vasopressor drug therapy may be necessary in patients with inadequate tissue perfusion and adequate intravascular volume, so as to maintain mean arterial pressure of 60 to 65 torr. Diuretics are used to decrease plasma volume and peripheral edema. Dopamine is chosen to improve cardiac contractility. Norepinephrine can increase blood pressure successfully in patients who remain hypotension after administration of dopamine. Epinephrine can be given to increase the mean arterial pressure by increasing the cardiac index and the stroke volume. Ventilation. Oxygenation and airway protection are critical. Intubation and mechanical ventilation are commonly required. However, although positive pressure ventilation may improve oxygenation, it may also compromise venous return preload to the heart. PEEP must be monitored closely in order not to compromise cardiac output and cause further hypotension. Arterial blood gases need to be managed to provide adequate ventilation and oxygenation while maintaining minimal amounts of PEEP and high pressures. You will need to monitor PEEP using the 50-60-10 rule. So you'll go up from the oxygen FO to 60%, and then you will start increasing the amounts of PEEP. You will increase PEEP until you have a hemodynamic deficiency, either shown by a decrease in blood pressure, cardiac output, urine output. At that point, you'll stop the PEEP and begin increasing the FiO2 further. The overall in-hospital mortality rate for patients with cardiogenic shock is 57%. For persons older than 75, the mortality rate is 64.1%. For those younger than 75, it is 39.5%. Mortality rates are similar for patients with cardiogenic shock secondary to STEMI or NSTACs. So basically, cardiogenic shock is caused by a problem within the heart that essentially just completely stops blood flow. Obviously, this is going to result in decreased or no oxygenation of the tissues, which eventually will lead to multisystem organ failure. Now we'll go on to obstructive shock. Obstructive shock is caused by the obstruction of blood flow to the body tissues. Obstructive shock results in bodily collapse or near collapse caused by inadequate oxygen delivery to the cells. It is characterized by reduced cardiac output, rapid heartbeat, and circulatory insufficiency and power. Common causes of obstructive shock include cardiac tamponade, narrowing of the aortic artery, tension pneumothorax, and massive pulmonary thromboembolism. Other obstructive shock causes that are rare include valvular stenosis, cardiac tumor, pulmonary hypertension. Obstructive shock is commonly classified as a type of cardiogenic shock. With that being said, obstructive shock and cardiogenic shock present many of the same clinical manifestations. Patients suffering from obstructive shock will often present with the following clinical manifestations: skin, pallor to cyanosis around the mouth and the nose, rapid weak pulse, cardiac dysrhythmias, particularly premature ventricular contractions and atrial fibrillation, rapid shallow breathing, unconsciousness, weakness, confusion, anxiety, feeling of impending doom, restlessness, altered mental status, hypothermia, thirst, dry mouth, fatigue, distended neck veins. Now I will discuss in further detail the main causes of obstructive shock. Cardiac tamponade. Blood in the pericardial sac prevents venous return and contraction of the heart. It's usually related to trauma, pericarditis, myocardial infection. It presents Beck's triad, hypotension, muffled heart sounds, jugular venous distension is part of the diagnosis. You need a large heart chest ray, an echocardiogram to help produce a diagnosis, and the treatment is pericardiocentesis. Tension pneumothorax. Air trapped in the pleural space with one-way valve air pressure buildups. Tracheal or mediastinal shift toward unaffected side, causing impending venous return. Symptoms: chest pain, shortness of breath, decreased or diminished breath sounds on the affected side. You can also have a chest x-ray if needed. Treatment: needle decompression or a chest tube. Pulmonary embolism. You will observe Vers-Powell's triad of hypercoagulable, venous injury, venostasis. Signs will be tachypnea, tachycardia, hypoxemia. Low risk diagnoses will be a D-dimer. Higher risk for diagnosis, CT, chest, or VQ scan. Treatment: heparin considered thrombolytics. Aortic stenosis. Resistance to systolic ejection caused by decreased cardiac function. Chest pain with syncope. Systolic ejection murmur. Diagnosed with echocardiograph. Vasodilators will drop the pressure. ventilation for obstructive shock follows the same basic principles as cardiogenic shock. The patient needs to be ventilated and oxygenated while maintaining the least optimal positive pressure. Peak levels need to be monitored closely in order to prevent compression of the heart and further decline in cardiac output. ABG should be taken, and the patient's minute ventilation and oxygenation parameters should be adjusted to keep the patient at an appropriate baseline for that particular patient. If the lungs begin to develop ALI or ARDS, protective lung strategy protocols should be instituted. Once again, you would institute a protocol for a tidal weight of 6 to 8 mL per kilogram of ideal body weight. You would identify the diagnosis of ALI or ARDS by looking at pulmonary artery pressures and pulmonary capillary wedge pressures. If you have an increased pulmonary artery pressure with a decreased pulmonary capillary with a normal decreased pulmonary capillary wedge pressure, this would indicate that there is a lung problem and not a heart problem. Once again, all these forms of obstructive shock will cause a decrease or eventually a complete stop of blood flow to the systemic capillary bed and the pulmonary capillary bed. The stop of blood flow causes tissue death, injury, and multi-system organ failure.